Excuse me while I clear my food. So, welcome to this.
Stand.
Oh, sure.
Okay.
Where's the microphone? Oh, I see. Oh, there's a video. Yeah. So, I want to welcome everyone here and online. I'm not sure how many people are online. For those of you who don't know me, I'm Kevin. I'm a neurologist at NNI, but I'm also co-lead for CIPHE, our Center for Interprofessional Healthcare Education. And I'm very pleased to be here to introduce Samrat. Samrat Das is a professor of pediatrics from Duke, Durham, and also the UME director. And he comes with an interest in IPE. He's been here since Monday and on the Duke travel grant. So this is a grant that allows Duke faculty to travel to Duke NUS in Singapore to share and interact and collaborate. Someone happens to be the first educator who has come to Duke NUS on this grant. It's usually researchers who do that. So he's going to share with us his experience on developing an observational tool for IPE. Right. So, Samrat, thanks.
Thank you, Kevin. Good afternoon, everyone. Is this working? Or...
Yeah, you don't need to put.
Okay. Do I need a microphone or is that good enough? No need for microphone? Okay. Okay. So, thank you all for coming this afternoon to listen to talk about interprofessional education. I have been very impressed with how many champions this place has for interprofessional education. And I have been telling everyone that you're far more advanced than many other institutions globally in terms of IPE, because you have IPE components in different places and you have lots of IPE champions. So you have a lot of bottom-up people who really care about this, and so you are all in excellent hands with CIPHE and all of the individual people who are here and the various champions. So what I'm going to talk about today is not so much, why IPE, and I'm sure you all know why IPE is important, and that's why you're here. It directly impacts patient outcomes. So this is not something just education. It doesn't do anything. There's enough data to back it up. This actually impacts patient outcome. So I'm not going to talk about outcomes today. I'm going to talk about process design on about what we are doing at Duke to observe people's behavior change. It is one thing to teach certain principles and expose them but it is another thing to actually see if there is a change in their behavior, because a lot of us, if we are clinicians or non-clinicians, in our busy day, we know that we forget things. Unless it becomes a habit, we forget things. We may be a big IPE champion, but when it comes to actually doing things, we don't know whether we are doing that or not. So we developed this tool, which it is in its second iteration, to observe learners and professionals about their behavior change. And then, I'm going to talk about the process that we followed. And I hope that knowing the process will give an idea of how iterative the process was, and how much thought has gone into it, and how much collaboration has happened to come up with this tool. And hopefully there are opportunities to collaborate on this tool in the healthcare system here so that we get more robust data. So we all know that IPE is being implemented. Everyone is recognizing that it is important. But what we don't know is, whether we're not being good about observing change of behavior. That is across, the globe. We're not good yet on observing behavior change. Part of it is we don't know how to observe. And that's a global problem. It's not just a problem here or at Duke Durham. It's a global problem. We just don't know how to observe. So a lot of the IP evaluation, as you may have seen in the literature, is surveys, self-assessment surveys. You check your own attitude and then and perceptions, but and confidence. But we know that change in attitude or perceptions or confidence does not mean that they're going to change the behavior. And that's where IP is getting stuck. And that's a huge, huge literature gap because we just, we're not able to capture observed behavior. Even if we are do we know is that the right way to, measure behavior change? So IPE, interprofessional education, everyone knows about it. It is learning with and from and along with other professions, professional learners. We are all Duke, NUS, Singapore Health. You all are doing a fantastic job in trying to inculcate IPE. We're talking about the next step. How do we know that's actually making an impact on the ground? So again, if you ask learners after you do a nice workshop, they'll all endorse all the teamwork values. This is great. This is all important. It's so important. And then when it comes to action, oh, I'm so busy today. It was crazy. It was just too many patients. And sorry, I forgot to involve the other professions. That is more often the theme, right? So, and again, just because we are on a team of multiple healthcare professionals also does not mean that we are practicing IPE, right? Or collaboration. We could be part of the team, but we are just overwhelmed with, clinical issues and the issues that we need to take care of. And that's about it. So that is the other problems. A lot of the tools that are currently in the literature, they are confusing oftentimes exposure to IPE or IPEC with performance. They're all really not often measuring performance. They're more like exposure, attitudes, perception. And then a lot of the the observation tools in literature are relying on intent. That's hard to measure. We need actions to be clearly observed. And that unfortunately does not seem to be the case in a lot of the tools that are available. And once you're getting from observation what they're doing, what you can see to inference, that is a problem with the validity of the tool or validity of your observation, because your inference could be subjective. Every person has their own inference. So that's a huge, huge literature gap right now in the world of IPE, and that is coming in the way of successful implementation because healthcare leaders, what are they going to care about? They're going to care about outcomes. Are what you are doing, is it really changing behaviors? That's what they care about. So that's a huge gap in IPE. So again, like just an example of some of the tools, a lot of the tools will say demonstrate respect for team members. How do you measure that? That is relying on inference, right? It's not clear. that's very hard to just sitting in this room. How do I know a particular person has respect for other team members? I cannot see that. I need to define an indicator. This is what they're doing, and hence they have respect for other team members. And a lot of the tools do not have that. They'll just have demonstrate respect and then leaving it on to the observer to interpret that. The other problem with a lot of the tools is they've made these tools and saying this is good for all different scenarios, but all of the questions on the tools may not be applicable to your particular clinical scenario. So, and yet the tool is asking us to actually score it. And that's a problem. If the opportunity is not there to observe that particular behavior, how do we score it? So that's another problem we saw with a lot of these tools, and that leads to a lot of the false negative, because we are saying we didn't observe the behavior and we are marking it no. Actually, the opportunity was never there to observe that particular behavior, and that is resulting in false negatives. So that's a problem, because you're doing all this hard work, and if we use one of these tools and then it's coming up as negative, the outcome is like, oh, it's not a great intervention. But actually, there were problems with the tool because there were no opportunities to observe those behaviors. So those are some of the things, the groundwork when we were doing. We saw that the tools often ignore whether the opportunity existed, and opportunity was treated as noise rather than data. We thought that also has to be a data point, whether there was opportunity to observe or not. So that was another thing we did differently. And we thought that because of this, it could lead to unfair assessment. If a tool is forcing you to mark everything, and that could result into a misleading program evaluation. Your program might be stronger or weaker than what it seems based on that observation tool, and that could come in the way of weak research conclusions. So multiple problems with what we have in the tools. And I'm sure everyone recognizes that, right? I mean, there is a problem. This is a problem with IPE globally, and that is where IPE has not been able to make the progress, because we just don't have perfect tools or good tools to observe behavior change. That is where IPE is kind of stuck right now. So how did we, what was our approach? Our approach was, we are not going to measure everything. That was the first distinction we made. What we said was, we're going to observe what we actually can in clinical work. So that was the first distinction. We said, okay, that's great, IPE competencies does not mean that everything that is there needs to be observed, because everything cannot be observed. Okay, so we decided that we're going to focus on what we can actually observe in clinical work. So our first principle was behaviors that we are looking for to observe. They must be seen, heard, or documented, meaning clear, no inference, no interpretation. There's no place for interpretation. So non-observable constructs excluded, meaning if we have certain sub-competencies we thought we could not observe based on being seen, heard, or documented, then we are going to just exclude that. And when we say we, who are making these decisions? These are people from multiple professions from the beginning. So we have MDs, PAs, nursing, PT, pharmacy. All these people are making decisions from the very beginning, so that the tool that we are trying to design or have designed is applicable to all learners and all professions. Okay, so, and these are mostly experts in IPE, members of the core team of Duke IPE Center, and then some other people who are interested in IPE. So that was our first principle, the observability. The other principle we talked about earlier was, a behavior cannot occur without opportunity. So that was, we were very clear, if there's no opportunity, then if we say this is going to be good for all, then we need to make sure that we have that option of not applicable. The opportunity did not exist, because not having an opportunity should not mean that the performance was poor. Okay, and that was the problem with some of the tools. Now, most importantly, it got to fit into the clinical work, right? I mean, this is something that we all should be able to use it in the real clinical arena. So that was our other criteria, because if it cannot be really used in real clinical arena, then that's not a valid tool. Okay, so so I hope you are appreciating how practical we have been. It's a completely new approach to developing the tool. We are being very practical. We are first discussing what we can observe, and then is it really feasible? And then we are having professions from, all professions people involved in the discussion of developing this tool. And I hope this is giving an example of like how IPE should be tried, and it's like from the beginning have all the professions in planning, any clinical experience and all of that. It's good to have everyone involved from the very beginning. And then in terms of boundaries, who could be observer? We did say the observer could be or may not be the supervisor. We didn't have any particular rules for that, because we realized, again, we are being practical. If I'm going to ask one of my colleagues to observe a learner when they are on service already, that's more practical than me asking them, hey, you're off service now, can you go and observe? It's not going to happen. Right? So similarly, if I have a nursing colleague who I want them to observe the students, I'm going to do it when they are at work. So they could be or may not be observed, but for the purpose of developing this tool, we didn't want them to give any feedback right now, because we want them to just focus on the tool. We want to do this right and not, have any issues with learners at this point. We just want them to observe without them knowing, no feedback, and it's all anonymous. So that maintains, protects the psychological safety. So one thing I want to emphasize here is, why are we doing this? I mean, a lot of the tools, there is IPE, there's IPE competencies, and there are some sub-competencies, and there are some descriptions about sub-competencies, and the tool becomes like the sub-competencies, like we are trying to observe. Well, that is a problem, because the competencies and sub-competencies are a framework. They're not designed to be a tool. They're not observable behaviors. That's not what they said. Those are just some frameworks. So we need a tool. We need a tool. So frameworks are ideals, right? I mean, those are competencies, and they're very good. They result in skills, actually development of skills, but they are not observable actions. Any questions so far on what we're trying to do? Now, so with that background, how did we go about developing the tool? All of us sat down, different professions, and multiple rounds of discussions, and we reached a consensus on which competencies and which sub-competencies of IPE we can possibly observe. Okay. So that is the first thing, meaning we thought these are things that are observable. These are things we thought are important also. So we as a group made that decision. So what we absolutely excluded from our tool, because we wanted this to be a practical tool and not like a full summative evaluation, we wanted it to be practical thing. We removed anything that was talking about attitudes because we cannot see that, assumed intentions, and anything that relied on inference. We just excluded. And I'm going to show you what I mean from a table, what we did. And this was all an interprofessional group of people who was making all those decisions. And we had a structured prioritization of behaviors that we could observe, and everything was being documented. Like if we excluded certain things, why we excluded, because later on we should have a paper trail. This is the reason we chose these things, and these are the reasons we did not. We excluded those. So everything was documented and was done in a structured manner. And then that, preserved the logic of our decision making forever, because we are going to publish this. We have all of the decision logic preserved. And then this transparency, no one could say, hey, why is it not there? Hey, we did have this discussion. This is the reason we did not include this item in developing the tool, so that we can defend that in scholarship. And then we wanted to be a very balanced approach. We didn't want too many things to be observed. Anytime we had slight doubts whether we could observe this or not, we just excluded that. And we knew if a group of interprofessional faculty members feel this way, more than likely that's going to be the case every place else. It's the same stuff that is going on every place. So to show you an example of what we did. So this is one of the core competencies of IPE, value and ethics, and these are different subcompetencies. So we came up with a consensus of how important it is to a group of interprofessional people. Importance. How observable that subcompetency is actually, according to a group of interprofessional people. And then we made a decision whether we are going to observe that. We're going to make an attempt to come up with some actionable indicators for that subcompetency or not. So, for example, support a workplace where differences are respected, career satisfaction is supported, and well-being is prioritized. It's important. But the group felt that's going to be hard to measure. So that became observable. That score was low. The importance was high. So that became a maybe. We'll see. On the other hand, collaborate with honesty and integrity while striving for health equity and improvements in health outcomes. Again, very important, very hard to observe. Okay. But value the expertise of health profession and its impact on team functions and health outcomes. We thought it's very important. It got a 4.5 out of 5. And a lot of people thought that this is observable. So it got a good score there also. So important, according to a group of interprofessional faculty members, and observable, it's a yes, we're going to focus on that. Everyone with me, how we are developing this process on what to observe based on a consensus, what we think is important clinically and what we could possibly feasibly observe. Again, showing the rating. This is value and ethics. these are some observable behaviors, and then importance, observability. So if it is both are more than 4, we are including. If they are quite low, one of them, observability, is upholds professional standards in team conduct. We thought it's going to be subjective. A lot of subjectivity is going to be there. And when we say we, it's like all professionals thought that way. Okay, so we excluded those. So we are trying to come up with some real observable indicators. And then here, saying for the competency, and then I'm here assuming that most of us know the competencies and the sub-competencies for IPE. If not, I'm sorry, maybe I should have gone over those, but I'm assuming that most of us know there are competencies, 4 competencies, interprofessional education, and then within those competencies, there are sub-competencies. So this is a yes. Value the expertise of health professional and its impact on team functions and health outcomes. It was a strong yes. People thought it's very, very important for IPE and collaboration, and people thought this is something we could observe. So people came up with some indicators. Again, a consensus that we thought we could actually observe. So competency and sub-competency, this is a framework. You can't observe this. We came up with which framework we could actually observe clinically, and then came up with these indicators as a consensus. These are things we can actually observe. Any questions so far? Okay, now everything that is mentioned, not everything became indicator, because within these indicators, like these are a lot of people, different people coming up with this indicator. Then we again met multiple meetings to say, okay, now this makes sense. This is something we can actually observe. So then we came up with the actual indicator that we can observe. So the behaviors or the frameworks then were translated into actual observable indicators, and they were professional agnostic by design. From the very beginning, from day one, there were multiple professions involved in every decision making. What is important, what is observable, what indicators, everything was based on input from multiple professions. Just to give you that example again, value the expertise of health professions and its impact on team functions and team outcomes. Some observable indicators that were from survey of all the professions. That does not mean that all of them were included. So say, are they consulting with other professions? That's, we can observe that, okay? Reaches out to different disciplines with questions to or provide helpful information. Are they reviewing data on health outcomes which may be affected by team-based care, reflection on team infection based on observation? Are they reflecting? And are they basically seeking input from other professionals before making decisions? Not all of them got into the actual tool, but some of them are giving you some indication as to, these are things we could potentially see in action. So we were very careful, in terms of the tool questions. We didn't want it to be too vague that it cannot be observed, but we didn't want it to be too granular also, then like it's going to be hard. Oh, I didn't see this, so it's not observable. We didn't want that also. So we thought it has to be a good balance for feasibility. And then we developed this indicator bank that I was showing. And then indicator bank is because we actually need certain things developed, documented, and we wanted the tool to be based on that so that there is no rater variability. Everyone knows these are the things they are going to observe for. Again, giving another example of how we came up with observable indicators. So referral to team members, how are they doing that? So consult, discussed, considered, initiated by the observee, consult recommended or placed by observee, other verbal written interaction with other professionals beyond consults, like in the Epic chat system, are they talking to other professionals? And are they talking about that during rounds? Are they documenting in the note that they spoke with PT and this they appreciate PT's recommendation? So these are things we came up with. This is not competency or subcompetency. We came up with these indicators. Okay. And then we decided, okay, these indicators can map which subcompetencies and when they can be observed. They can be, some of them can be observed during encounter when you're actually with a learner seeing a patient, or some of them could be developed later on after the encounter. So everything is done and you're looking at their note and seeing if they documented certain thing, they put in a consult note, they put in a chat. So this is again giving an example how we reach consensus, how we develop observable things. These are things we thought could be observed, how they are mapping to different subcompetencies. That's what we care about. And then when they can be observed. Can they be observed during seeing a patient or maybe afterwards? And then this is all we are deciding so that when we are using or you are using the tool, it's very clear. Okay, this thing you can observe maybe during the patient encounter. This is something you can observe afterwards. Okay, everyone with me? Any questions so far? Okay. And then we wanted to have two versions of the instrument because sometimes you may have the opportunity for just one IP encounter or one encounter with a learner or another professional, or sometimes you may be working with the same person for a week or for an entire day in the clinic. You may have a learner for the entire day in the clinic. So we wanted to make sure that the tools reflect like what setting it is. Is it like single time or is it like for an entire day or entire week? And then we had some rating anchors, and this all came from not just one time. We had multiple feedback iterations. People use this tool and they said, hey, we don't really understand like what consistently means, what sometimes means. Can you give us some anchors? And then we came up with anchors like sometimes means anything up to 75%. Consistently is more than 75% times. And then we also had these anchors where there was no opportunity at all, and then we made sure there was an option for that. We didn't want them to falsely say negative if there was no opportunity to observe that. Okay. And why not applicable matters? We talked about this before because it prevents forced ratings, and we thought that's more fair and it's better. Otherwise, you will have a lot of false negatives. So again, going about like it's important to recognize and document there was no opportunity for that. So for example, if there is a observable indicator, observee did chart, documented this in the chart, but you as the professional do not have access to what they do in the chart, then you don't have that opportunity to observe what they're doing in their documentation. So then there should be a place for you to mark, there was no, the post-interaction marks not applicable because you don't have the opportunity to do that. Similarly, if there's no pharmacist present there and there was a medication decision made and one of the indicators is asking the got input from pharmacy or not. Well, there was no pharmacy there. How would you have the opportunity? So there should be a space for that. And unfortunately, a lot of the traditional tools actually currently in literature still force you to mark that. Okay. So, and the last thing we made sure we put in the tool that complete, not right away. We understand like people are busy. We don't want them to forget about it also. So we took a balanced approach. We said like complete as soon as possible, reasonably possible. Okay, because if you ask them to do it right away, well, they may have patients to see, other things to take care of, and may not get to the tool. But we don't want them to be doing this like 2 weeks later, because then you're going to have a recall bias. So we did a pilot of this tool, and there was lots of broken items, and that's why you have to pilot and do multiple iterations. There were some ambiguous items. They didn't understand, the people who observed, like what those meant. There was still an opportunity confusion. They were not sure if the opportunity existed, and they thought the instructions were not clear. How to use the tool. The instructions were in a separate Word file. They didn't know how to get to it, so there was some confusion. These are some feedback from the observers. They thought the instructions were unclear or difficult to locate. There was ambiguity regarding observation scope. And then the rating scales, we didn't have that at this time, like 1 to 75% or 75% or more. We didn't have those at that time. So those were some feedbacks based on which we clarified our instructions. We put in anchors and gave more examples what those mean when you talk about those observable indicators. We gave specific examples of what to observe. And then we have the kind of the tool almost finalized. We are going to have one more iteration before we say we are ready to make it a valid tool. So this is how it looks right now. So these are the tool instructions. So this is the purpose is to directly observe interprofessional behavior in real clinical settings. And then this is just for observation. This is not to give feedback, or, and it could be for single encounter or longitudinal encounter over multiple encounters. And then these are our core principles, based on opportunity present or not, feasibility, and then observability. And these are the rating anchors. And then single encounter could be just a bedside handoff, or a single encounter, single patient that they see, and then longitudinal is over a week or whole day clinic. So this is the tool. This is how it looks. This is the single encounter version. These are some of the instructions. We clearly say here what consistently means, what sometimes means, when there is no opportunity. So observee name, observee role, medical, PT, OT, nursing, PA. It's good for all professions. What is their role in the team? What are they doing? Why are they there? Date, time when they were observed. And then different sections, competencies and subcompetencies. So referral to team members. Are they initiating discussion relating to another profession? If no, who initiated that? Someone is doing it, right? I mean, when we are working as a team, someone is doing it. So if they didn't do it, who did that? And are they putting in consult? If they did not, then who did it? Okay, so these are pretty like obvious things that people can fill out, we think. And then interaction with team members, where there's some nonverbal signs of active listening, like nodding. Was there clear evidence of positive interactions? And there are clear anchors, consistently, sometimes not at all. And then use of structured communication. Are they using team steps or SBAR or things like that for communication? Role clarification. Are they correctly addressing the other person, other profession with the right title? Are they describing the other professional roles correctly? Are they describing their own role correctly? So these are some of the indicators. And then acknowledgement of professional contributions. Are they acknowledging, appreciating other professions' input? And then some post-interaction behaviors. Are they documenting things? Are they interacting with other professions through Epic Chat or whatever, medical record that you have system, electronic medical record system you have? Are they interacting with them, or are they putting in their consult notes, in their notes that they consulted and the reason for consulting, and putting in their recommendations? Written interaction with team members. Are they, again, doing structured communication, or they have documentation of interaction with other team members? So these are, and this is the longitudinal version when you have seen someone on multiple occasions over a period of time. But other than that, the rest of the thing is almost the same, observee role, and then the observation period instead of date, and then everything else is the same as the single encounter version. During versus after interaction example is very simple. During is right when you're observing things, and then after is once the encounter is done, you're looking at the documentation of shared plans. So some lessons learned. We thought it's important to be practical and decide first what is observable, because right now the tools are all over the place. It's very hard to use those tools because we have IP initiative. We did not feel that those are the right tools for us to be observing the behavior change. So we wanted to come up with something, and then we first decided what is observable, and then make sure that the opportunity is there, and then we designed it in a way based on importance and observability in real clinical environments based on input from multiple professionals. So we are not claiming by any manner that this is a complete measure of teamwork and it's a summative tool. That's not what we aim for. We wanted to be practical. We wanted to see some real behavior change that we thought are important for all professions. And that's how we came up with this tool. So again, our principle was that, honesty beats precision, and we are not claiming that we are accurate, and we did not want to do that. We just wanted to have a more practical, honest tool, and we know we are going to publish this. So there's a scholarly component of this because there's a lot of iterations and a lot of thought that has gone into developing this. So again, we wanted to have clear guidance because ambiguous instructions and the data that you get, you can use tools. I mean, the question is, and do observation, the question is it real data or not? Okay, so that's our problem. We were not convinced that it was not noisy data. So we came up with this, and we thought it's important to have, a tool that is good for multiple clinical scenarios and multiple different teams, because team composition varies. So that's why we have multiple professions and their, experiences go into developing this tool, and it's important to acknowledge that opportunity may not always exist for all of those actions to be observed. So that is all I have. I'm happy to take any questions. I hope it was meaningful. The exercise, how I think the reason I wanted to talk about this is for two things. It's a scholarly innovation we have done at Duke, number one, based on a big need in this field of IPE. There is not a lot of good tools that's usable, and that's the reason IPE is not progressing to the next level. So we thought it was a very important need, and we thought, it's an innovative thing. And then I wanted to highlight the process we followed, the design we followed, and how iterative it was, and how it was based on consensus from multiple professions to begin with, so that the tool could be implemented for multiple professions and not just. Thank you.
Thank you. We do have time
Okay, what's the
for questions. We're about 10,
Okay.
10, 12 minutes. And
Yeah.
can we take questions from online participants as well? Or we can't? Okay. So
Yeah.
we rely on the on-site participants.
Go ahead. Yeah.
If I understand it correctly, one person is being observed at any one time. And how many observers are there? Because it is interprofessional, so maybe more than one profession needs to observe.
That's a very good point. Right now, we are developing the tool. So right now it is one observer, but that may not be a person in that profession, could be anyone who volunteers to do the observation right now. Our belief is that this could be used by any profession and for any learner, and interchangeably. Like you could observe an MD using this tool, or an MD could use this tool to observe a pharmacy student. But right now, you have a very good point. Is it one can a should a observer be observed by multiple people or not? We have not thought about that. It's a good point. But right now, it's just one. It's not profession dependent, but it's one observer right now observing one observing.
The second question is, if it's meant to be non-summative, and the target observed, the people who will be observed are learners, assuming they are students. If it's non-summative, we know our students will study to the test, right? So if it's not a test, then how did the student take it, and how do you overcome Horton effect? That because I know I'm being observed, so I behave.
Yeah. It's a great question. See, my philosophy is that this is something we want this to be a habit, right? And we do want to provide a psychological safety to the student. This has not become mainstream yet for us to be doing a summative evaluation. I think our best chance for IPE to survive and flourish is to make small steps and give them feedback formative that, these are things. I think they're all adults, and with good feedback based on a good tool, that this is what we observed and these are the changes you could make. I think I would leave it there and not go to grading, because for two reasons. One is psychological safety, and the other reason is we are not doing such robust curriculums yet, right? I mean, these are bits and things, pieces we are doing right now. Then it may not be fair to judge them based on how much we are doing. They are having a full curriculum to enhance their medical knowledge about everything and patient care, and but are we doing that much for IPE? We're probably not. So it may not be fair to do a summative evaluation at this point.
I agree that it will serve as a very good formative tool to help them identify their own
Yeah.
needs.
Yeah.
And as long as we spell it upfront that this is not summative and this is just to help you in.
Right, right. And there is a lot of different things that we all could do. And number one thing is good role modeling, right? Like, I ask myself this question when I'm rounding and I have other professions. How many times, actually, it's a simple, like, I want to change myself. How many times after we talk about the patient, am I taking 30 more seconds or 1 more minute to ask pharmacy, did you have any input? PT, did you have anything right now? How many times am I role modeling that behavior? That is what I think is going to change the learners, right? Like when we role model this behavior of getting everyone's input and not going to the patient and saying, you're going to be discharged tomorrow when they have significant PT and going on right now without even getting the input from PT, whether they're ready to go home or not, just based on my assessment. If I'm saying they're ready to go home, that is poor role modeling. And then the PT comes in and says they're really not ready. They need to go to rehab. And that's just bad in front of patients and learners. So I think there's a lot more we have to do in terms of good role modeling before we go to the extent of summative evaluation.
Okay, thanks, Kintin.
Yes,
Yeah,
Nigel.
well, thanks for a really interesting talk, and I really like the fact that you brought in the opportunity part, which I think many tools actually do not bring in.
Right.
My question pertains also riffing off Tingting's question. It would strike me that the early part of validating the tool, you probably need two observers. You need to see how the inter-rater reliability is.
Okay.
Would there be plans for that? Yeah.
That's a very good question. We do have plans for that, but we have not gone to that. This is the second iteration we are doing. That's a good point that I'm going to take home, that feedback that we need to have, two observers doing the same observer. That would be that's an important point. Yeah. The good thing about this work is we have, like all the professions, but we also have statisticians who are experts in validation part of the tool, who are very much part of the project, so who are in every meeting. And in fact, they are the ones who are running the meeting to make sure that later on we don't do anything that's not validated. But that's a great point that I'm going to take home and make sure we do. Yeah.
Yes, Changwei.
That's of how you got to this point in time. So one of the questions would be some of the sub-competencies, right? When I zoom in to have a look at a few, they had multiple variables in one sub-competency, like I don't know, identity, autonomy, and diversity, for example. So how do we get from the sub-competency to the survey part of it, where kind of
So within the competency, there are multiple sub-competencies. So the sub-competencies, we reached a consensus, the ones that are important, and if important, are they observable. So some of the things that you said, we right there cut them off. Like, we did not think that they are observable. They were important. They're all important. That's why they are in the framework. But we did not think that they were observable. So we cut them off. So when we did the indicators, we did for everything. But when we were looking at the indicators, we can clearly see they're not observable. So to answer your question, we finalized the indicators for only the sub-competencies we thought are important and observable. And how we made the decision whether they're important and observable is the consensus part and the statistician. Yeah.
Be able to use in different
settings. That is our hope. That is our hope, that we have tried to be as practical as possible, and we have the option of opportunity did not exist. So you're not forced to mark something that you do not have the opportunity for. But we think there is enough in it where everyone should be able to use part of it.
Okay, I have a question
Yeah.
of my own. Do you think that in the implementation of this, will you need to do any rater training? You know, because sometimes some of these concepts, you know, you have to frame it for the rater. Some tools do it by providing descriptors. You know, others you actually need to go through
Yeah.
some form of training.
Right. So we have thought about it right now. Based on the first round of feedback, we came up with those anchors, like 75% or more than 75%. So we will see what the feedback is after putting in more clearer instructions and the anchoring. If it is still a confusion, then we may have to do rater training. However, the reason we want to potentially avoid that is because we want to make these tools so simple that anyone could use it. Because if we collaborate and we want to implement it at one of your health system, it's going to be very hard for us to, train everything, because we are all, as a community, struggling to even do faculty development on what IPE is. To get to that stage will be difficult. So our hope is it is very clear from multiple raters that no, that was easy, that was easily understandable, more than 75%, less than 75%. It was easy for us to do. That is our hope. But if that is not the case, then we know we have to go to that. Thank you for that question.
Okay. We have time for maybe one last question.
Thank you all for your
If not,
attention.
yeah, we can end 2 minutes early.
All right.
Thank you.
Thank you. Thank you. So do we take a 5-minute break and
Yes, so following the lunch talk this afternoon, we have a workshop. Is it going to be here? It's here. Shall we take a break and we have to reset the room? How long? How much time?
yeah, it's fine. Yeah.
And is there more food that people can? Yeah, so if you haven't had enough food, there's more food.
The next session is gonna be all interactive and us learning from each other. We are all gonna learn from each other.
Thank you.
Thank you. I'm gonna get some water.
Yes. Hey.
Take the water. Yeah.
Oh, yeah.
Then how many you all want? 2 groups. 2 groups. 6. 2 groups. Yeah, then we do that. So how? This one cannot, the small one cannot, the big one can. Can it? I think the big one can. Yes, correct. Oh, the bar. Why very long? Oh yeah, okay. So how 2 or 6? Yeah, that means we got to keep the kantao. Should we record what? I don't think so.
We leave that one first, later think about it. And we settle the two groups.
Laptop haven't died. Ooh.
Why this one don't have the bar?
Okay.
This one no bar.
Yeah.
I don't know.
Spoil
This one has, this one has.
This one spoil already.
Okay, then we use this table lah.
Okay.
The next one got bar. This one need to unlock.
You want to borrow your charger instead of me?
This one don't need already, right? Okay, fuck it out. The clean down no need. Oh, then my laptop die also no mind.
The speed of innovation would mean, I think who was saying that, right? I think you were there was backtrack the back. This episode.